us together for the first of its kind health fest, Aarogya Nagari. This unique concept has been devised by the medicos of Dr. V.M.G.M.C Memorial Government Medical College, Solapur for the benefit of common man on the occasion of 60 years to the establishment of this prestigious institute titled as Hirak Mahotsav. Before commencing the conference, I would like to invite our respected chairperson, Dr. Rode Sir, Assistant Professor of Department of Surgery, to welcome our chief guest, Dr. Nirmal Tapadia Sir. Round of applause. I request our respected chairperson, Dr. Day3 Sir, Assistant Professor of Department of Physiology, to welcome Dr. Rode Sir, Assistant Professor of Department of Surgery. Huge round of applause, please. On that note, let's commence the event. Many of us here have a lot of queries regarding the fate of medicine overseas. Which country is best to study medicine? The salary over there, government job is preferred or private practice in foreign countries? How to apply for universities? I am sure that after today's session, many of these queries will be solved. I request Dr. Nirmal Tapadia Sir to enlighten us on the prospects of medicine in foreign countries.
Okay. Good morning to all the students who have come to hear me, and I thank the organization committee of this Aarogya Nagari to have called me here in V.M.G.M.C Medical College after a gap of around almost 20 to 25 years. I have given many lectures on many dioceses on the national forum, but this one is special to me when Rohit told me that you have to deliver a lecture on studying medicine abroad. For 1 second I was surprised basically. Students who are studying in second or third year MBBS, so why they want to study abroad immediately? Because studying abroad came to my mind after 10 years of my medicine practice I had started. Let me tell you that you have a common studying room here in the premises. Okay, so there was a tree in front of the compound. So I used to put my chair there way back in 97, 98, and I used to study for my common entrance exams. I used to sit there for hours together and then used to have a break in the canteen. I don't know you have a canteen now in this premise. Okay, so I have a lot of my preparation memories associated with this hostel and associated with this college. Now, the subject which is given to me was specifically very relevant because after completing my MD degree from GMC Miraj, I had started practice in clinical care medicine. I was very interested in ICU care because of my aggressive approach to the patient, aggressiveness in my nature. I thought I am a fit person to practice critical care medicine, and I had a good success in practicing critical care medicine. I had good number of patients, everything was there. Then I attempted Indian Diploma of Critical Care Medicine in 4 to 5 years after my practice. I passed the exam and I again started practicing. Then I realized that studying in India, we are Indians, we have a good infrastructure, we study good medicine, we have good teachers, we have good textbooks, everything is fine. But when I started practicing and I started forming my own concepts in the practice of critical care medicine, when I started writing down papers in the journals, then I realized that the methodology of study, especially higher degrees or post MBBS, somehow is not adequate. Not adequate in the means it comes in patches. Actually, you are taught a topic, you are taught a subject, then you are taken exams. Exams are also taken randomly. Most of the exams in our universities are dependent on the examiner, as you all know. It belongs to the whims and mood of the examiner who comes to take your exams. There is no format in the exam. For example, if you have a case of, suppose, pneumonia or hepatic encephalopathy, I may ask questions straight away on hepatic encephalopathy, whereas sir may ask you case on surgical aspect of or treatment of uh, tips basically, or on the surgical aspect of treatment of hepatic encephalopathy. But uh, but this does not, see, patients have, one single patient has various aspects. I'll give you an example of pneumonia. Okay. Now, a patient of pneumonia comes to you, you diagnose it as having pneumonia on X-ray, but that pneumonia has at least 25 variants. Okay. The approach to the patient of pneumonia, there are two ways. One, you can start directly with giving a blanket treatment, we call it as nowadays. Most unfortunately, most of the Indian scenario gives, we are in a very hurry to treat the patient basically, hurry to give results and hurry to show them that you are best than others and you can do it very fast. There are no miracles in the field of medicine. Okay. Now, a methodological approach in the patients of pneumonia, for example, you get the history of the patient, you get the occupation of the patient. These are all very basic medicines, but how does it differ in the treatment? I will tell you. Recently, I had a case from the periphery. Patient was treated for 10 to 12 days in a hospital. Patient started worsening. He was on oxygen. He was given BiPAP ventilation, and the patient went on to 10 to 15 liters of oxygen. Patient was on, I think, 3 to 4 antibiotics. Patient was on anti-malarials. Patient was on doxycycline. Patient was on antivirals, but still the patient failed to respond. Then one night I had a call that the patient is landing in severe respiratory failure and will be admitted under you. Patient came to me. Now a patient of 10 to 12 days in a hospital had come to me at 1:30 in the night. They had all the time in the day, but patient was referred to me at midnight. Okay. When I saw the patient, when I took history of the patient had a history of mild cough and all these things, low grade fever. Patient had breathlessness which was progressive in nature, and X-ray and CT scan showed something very unusual on this patient. Okay. All the CT scans of pneumonia, almost they look alike unless you are trained to see through the CT scans what are the subtle findings of various different types of pneumonias which are there. Okay, and the patient had some AIP, acute interstitial pneumonia or Haman-Ridge syndrome basically. And what I did was, first I stopped all the antibiotics. Only one broad spectrum antibiotic was given and steroid was given to the patient. Basically, the story is patient has an inflammatory type of pneumonia. It was a non-infectious type of pneumonia, and what patient required was anti-inflammatories, good doses of steroids for 4 to 5 days. And you won't believe, patient after 5 days was on almost 2 to 3 liters of oxygen and off BiPAP, and 7th day she walked home. All I did was I stopped all the antibiotics, okay, and given steroids because I could diagnose the case as it was a non-infectious cause of pneumonia. And how did I come to know this? It was because I after taking Indian Diploma of Critical Care Medicine, and when I was unsatisfied with the way that it was taught and the exams were taken. I attempted European Diploma of Critical Care Medicine in UK. Okay, now these are two similar degrees. One is Indian and one is European diploma. Okay, but what difference I found was, number one, they were the originators of critical care medicine. Critical care medicine had started way back in 75, 80s, and it was developed by the European and the American society. But the basic concept of ventilators and all this started in Europe. So they were the ones who developed the field of critical care medicine after years of their exhaustive research, and they were the masters basically to treat critical care, to teach critical care medicine. So when I started attending their seminars, I started attending their classes. We used to go twice a yearly for the training sessions. I found that there was a huge difference in teaching pattern. Okay, they used to teach very in a very productive manner, in a basic way basically, and in a very precise way. A patient of sepsis comes to you, you start all fancy antibiotics, you give fluids to the patient, you start noradrenaline to the patient, and you give oxygen to the patient, and immediately take seriousness consent of the patient to the relatives. You inform that whatever happens is because of you and not because of me, and you shift the patient to the ICU and get rid of the patient. One simple thing is forgotten, that as soon as the patient comes, you have to take the blood culture of the patient, because it is a septic patient, and give IV fluids to the patient. Okay, and give antibiotic within 1 to 2 hours. That is what the patient has come for. He has come in sepsis, he has bacterial infection, and you need to treat with first good dose of antibiotic. So in our system, we have a paragraph on management of sepsis. The most important point in management of sepsis when the patient comes in is not, unfortunately, is not being stressed upon or not being taught. And exactly half marks of that case are given for this point. When in the exams they give a case vignette there. We had a case vignette, for example, any case of bacterial meningitis, case of septicemia, or case of myopathy, basically myositis or cellulitis. They used to train in such a way that we had the most, see, a patient of sepsis in shock is going to die because of septicemia. Unless you start controlling that, you give whatever doses of anadrops or IV fluids, patient is not going to survive. And this you will understand after 12 to 24 hours. By that time you have already made a mistake. So these things, what things to commit first in a case of critical care medicine, and what things are to be avoided, and what can save the life of the patient. And when you treat the patient, you have to compare yourself with the outcomes of similar cases which have been treated in good or in very renowned centers. This is called as benchmarking. You compare your 50 to 100 cases of ICU admissions, their death numbers, their mortality rates basically, to ICUs where good care is taken, standard critical care is taken, and then you read those cases and then see what has been done wrong to the patients. In this you start growing yourself knowledge wise, experience wise. And second thing is, you see, I will tell you one thing: when you start practicing medicine or any subject or any faculty for your purpose, only gross mistakes or gross blunders are seen by general public, by people, for patients' relatives or other hospital staff. Very minute details of the case, very minute mistakes and mistiming of the treatment is noticed only by the consultant who treats the case. Okay, only consultant who treats knows that at this time I should have done this, but it was not done by me. This happens because of lack of proper not training, I may say, because we have a very different way of practice in our country. Basically, we have practice is on the number of cases, on the number of OPD, how much your income is, what type of car you are using, how many bed hospitals you have. These are the parameters in way a practice is measured in India. No doubt, financial matters do matter, and we should have number of patients, but the care provided to the patients, the quality provided to the patients, and the ethics which has to be implemented while treating the cases and while practicing medicine or critical care medicine, this has to be learned in a proper way. If you are practicing for 30 to 40 years of your life, you have the right, or the patients coming to you have the right, that your doctor knows the best uh, course of your subject, the best part or the best training of the subject for which he has come to you. Basically, there are no short cuts in medicine practice or in any practice. So, to when I realized the difference between these two, IDCCM and EDIC, and I was very thankful that in the right time I came to know about EDIC. Uh, I dared to attempt it because that time I had a full blown practice. I had good, very large number of patients, OPD as well as IPD. I used to study after 11:30 p.m. in the night. When I used to come home, I used to study till 2:30 and then get up early 8 o'clock in the morning. So I had to do all this struggle, but it was worth it, because when I gave the exams, I came with the education, I came with that knowledge. When I started in my ICU practice, it gave a tremendous boost to my practice, or to the quality of the patients. The diagnosis I started making, the ABGs I started reading, basically, it had a lot of impact. The precision of the diagnosis with minimum investigations and the treatment, the time to treatment, all this changed a lot. And this made a huge difference in the way that when we had a COVID pandemic, basically, I had in the district maximum number of COVID patients, and I have treated a huge ICU and non-ICU COVID patients to the tune of around 2000 to 2500 in a single unit, which was run by me. And we have published a study recently on parameters of COVID and mortality of COVID in our ICUs. Surprisingly, the rate of mortality in first or second wave of COVID, though we had limited infrastructure, we did not have drugs like tocilizumab, we did not have oxygen ventilators and all these things, but on the basis of knowledge and the basis of training I had, on the basis of triage, everything is taught over there, and we could save a maximum number of patients. The mortality rate was at par with the ICUs, basically, in metro cities, and we could give the treatment, and we could understand COVID as much as they could understand. It was all because of my number of years of study which I studied in India, and EDIC had given a good boost to my perception of critical care, and that was the difference. I could compare one to one what was taught in IDCCM and what is being taught in EDIC. So whenever you get any opportunity to learn abroad, to have a degree abroad, or to have an interaction with the doctors over there, I think in your life at least once you must try to attempt that, because practice is going to last for 35 years. You are going to earn money, you are so well educated, you are so qualified, and you are one of the topmost brains in the society. So no doubt all these things follow you, you don't have to run behind them. But what is important is give a good treatment, ethical treatment to the patient, to the satisfaction, with the best resources, and save their money, save their time. So that can be learned, basically. We have some minor points here just to complete it socially. There are 5 to 10 points. I'll just read out. I just wanted to share my knowledge today. Basically, this was not a subject why we should prepare slides and teach you, but okay, we'll directly go to the reasons. Broad, wholesome, charitable views of men and things cannot be acquired by vegetating in one little corner of the earth all one's lifetime. We directly move to the points. Okay. Travel the world and have new and exciting experiences when you go abroad and educate yourself enroll yourself for a degree there. So seeing pictures on the internet or in textbooks is different, and seeing the things over there, it is a thrilling experience. It is a very rich experience. Staying there and learning with all the doctors and all the people coming from different parts of the world, interacting with them, knowing where you belong to, what is your stature, what is your caliber. So you come to know all these things. Second point. Just one. So college time and post degree is the best time for you to travel. You don't have any responsibilities of your family, of your home, and you can roam around for 2-3 years and learn your education. We gain a new perspective of your home and country, what people think of your education system, what people think of Indian doctors, what people think of public over there. You come to compare and know the things. Third point. You explore your heritage. We learn a different language. We try to know the concepts of people living there, their culture. You become a professional and have bigger chances of success. You have bigger opportunities. You have opportunities to work abroad. If I wish to go to Europe and practice medicine there, it is all the very easy for me to have a secure job over there, because I have learned their degree. I practice medicine and I have taken a diploma from there. So for any time I can just go there and just work somewhere. We have the opportunities which are bigger than what we have Indian degrees. We become a full-time learner basically. We gain many new friends at the international level with whom you can have lifelong relations. You can always discuss difficult cases. You can always discuss what trends are going on. You can fight stereotypes of treatment, as I have mentioned here in while treating. You dispel your own stereotypes, some false beliefs which you had developed while taking education here. You take better control of your future because you have international opportunities, you have many possibilities. Okay, so that's what I just wanted to have a highlight and basically get you aware of the thing that if you have opportunity, not that everyone can study abroad, money is involved, or it is compulsory to study abroad to take a foreign degree and just to show that I have a foreign return. It's not like that. If you have a good liking for a subject and if you feel that you have to achieve success and the heights in your profession, then you have to have the best of your skills and best of the armamentarium. You just cannot talk with a low degree background and then you have you have recognition from the medical fraternity as well as from the patients and the relatives or the general public. Okay. Thank you.
Thank you so much, sir, for your informative words. This shall definitely open new doors of opportunities for the medicos. I'm sure every one of us enjoyed the talk. We would be waiting for 5 minutes as the next guest lecturer arrives. I request Dr. Rode sir to maybe share a few words with the students.
Thank you for giving me opportunity as a chairperson. I am also V.M.G.M.C student. I have studied in the same library from the batch 2006, and sir, Tapia sir has given their very means in few words there are a lot of experience. Means they have learned many things over 10 years, 15 years and 20 years, and you and me are very fortunate to have to take this message at this time, and I request all the students to keep learning. We are always the students, so your attitude matters a lot. Is your tendency to take new new things, learn new things makes you perfect day by day. I request you, and I will appeal you to keep having enthusiasm in medical study, and keep learning at every moment. Thank you.
Thank you so much, sir. I request Dr. Doizet sir to please. Okay. We can take a break of 5 minutes maybe as the next speaker arrives. Please be back in 5 minutes in the same hall. We'll meet them. Thank you.
The importance is given to the treatment part or investigation. They are changing, but basic medicine, they are also examining patient like ours only. Na? Basic medicine is there only, but you have to give importance to basic medicine. You have to go to the patient with and check the patient clinically. When you don't go to the patient clinically, you don't know anything, the diagnosis will be a mess. How can you investigate the patient if you don't put diagnosis or don't do the diagnosis? That is the most important part. So, from your first year, second year, you start learning clinical medicine or clinical patient, clinical base. And when you learn more and more skills, then you will become confident. There should be no afraid of exams. Nowadays, 6 exams are there for university also. In medicine subject, 6. You have to face 6 exams. 4 in medicine and 2 in allied. So you become more confident at the time of university exam. So learn from patients also. And you see the patient in clinically more. Don't read patient what our residents written in history. They might be wrong. We have to learn. Many of the times what our UG students are taking history now, they are taking very detailed. They are my residents also. Many of the times I am telling, see, MBBS students taking so much detailed history now, patients. Then I learn from UG students also. So many patients I also not able to see all details now. You are taking one patient only, one student, one patient. You are taking very detailed history. I heard that history and go to the patient again. So history part is most important, examination is most important, and though you become super specialization, but basic medicine doesn't change. Basic medicine तेच राहणार आहे. जे काय आपण MBBS MD ला शिकलो तेच. That is clinical आणि basic medicine is very important. आणि व्यवस्थित you have to attend to the patients, take care of patient. And when patient became good after giving treatment, one smile always. When patient became good, he will give smile. Doctor, I am okay. I am now good. Give discharge to me. That smile gives us very power, big power of strength to save or to give management to other patients also. That is most important. That smile is very important. Smile of patient. That is he is satisfied with your treatment. वार्डमध्ये फिरून बघा आपल्या राऊंडला वगैरे किती पेशंट अगदी उठून बसलेले असतात, बरे झालेले असतात, नंतर हसत असतात. मी म्हणते माझ्या रेसिडेंटला आय एम टेलिंग माय रेसिडेंट सी दिस पेशंट इज स्माइलिंग दॅट आवर वर्क इज ॲटलिस्ट रीच टू दी पेशंट. ठीक आहे, ओके.
Anybody want to ask? Anybody? Any student? Sir.
गुड आफ्टरनून एव्हरीवन. मी हे घेऊन नाही बोलणं चालेल का? हे माझंच मला ऐकू येईल. जेव्हा मी PG साठी प्रिपरेशन करत होतो, म्हणजे MBBS झालेला आहे, इंटर्नशिप संपलेली आहे आणि आता पुढं कसा करायचं, काय करायचं, अभ्यास कसा करायचा.
आवाज येते पाठवा.
हॅलो. मग अशा वेळेस काय करायचं, तर आता हे सर आणि मॅडम जे सांगतायत की तुम्हाला एक खूप चांगलं क्लिनिशियन बनवू पाहताय, पण मला असं वाटतं की तुम्ही क्लिनिशियन तर बनावंच, परंतु व्हॉट इज युअर करेक्ट नीड, आता तुमची काय गरज आहे असं मला फील होत आहे. तर जे 7 सब्जेक्ट्स आहेत आपले, 7 सब्जेक्ट्स, ॲनाटॉमी, फिजिओलॉजी, बायोकेमिस्ट्री आणि सेकंड इयरचे 4 FMT, पॅथो, फार्मॅक आणि मायक्रो, हे 4 सब्जेक्ट्स तुमच्या टीप ऑफ टंगवर पाहिजेत. मी काय म्हटलं, हे 4 सब्जेक्ट कधीच बदलणार नाहीत 100 वर्षानंतर सुद्धा, बरोबर आहे. हे 4 सब्जेक्ट्स तुमच्या टीप ऑफ टंगवर पाहिजे. म्हणजे आपण जसं गणपती स्तोत्र पाठ करतो तसं हे तुमचं पाठच पाहिजे. डोळे झाकले की कोणत्या पानावर कोणत्या पेजवर दिलेलं आहे हे तुम्हाला आलंच पाहिजे. कळलं का? हा पहिला नियम, बरोबर आहे. ही तुमची शिदोरी झाली, ही कधी सुद्धा खर्च होत नाही, ही तुमची कायमची राहते तुमच्याकडं. आणि तुम्ही जे पुस्तकं विकत घेतात, पुस्तकं विकत घ्यायची आणि पुस्तकं विकत घेतलेले मार्क करायचे अभ्यास करताना. आता एक विषय, साधा विषय, तुम्ही फर्स्ट इयरला आले, बरोबर. ॲनाट, फिजिओ, बायोकेम हे 3 सब्जेक्टला तुम्हाला 1 वर्ष दिलं जातं, बरोबर आहे. हळूहळू शिकवून होतं, करेक्ट. आता तुमचं प्रिलिम येतं. प्रिलिमच्या वेळेस तुम्ही ॲनाटॉमी विषय 4 दिवसामध्ये संपवता का नाही? संपवतो का नाही? फिजिओलॉजी टायटल तुम्ही 4 दिवसामध्ये संपवतो का नाही? तो कॉन्फिडन्स आहे का नाही? मग हा कॉन्फिडन्स तुम्ही जो कॅच केलेला आहे तुमच्या ॲनाटॉमीसोबत, फिजिओसोबत, बायोकेमसोबत, तुमच्या वाचलेल्या पुस्तकांसोबत, हा कधीही ढळू द्यायचा नाही, बरोबर आहे. हे पुस्तकं कायमची सोबत ठेवायची. तुम्ही सुपर स्पेशालिटी MCS झाल्यानंतर सुद्धा जेव्हा तुम्ही PGM-CETला अभ्यास करणार आहात तेव्हा हे ॲनाटॉमी तुम्हाला 10 दिवसात संपवलं काय अवघड आहे, जे तुम्ही 4 दिवसात संपवलंय, करेक्ट. आणि पुस्तकं मार्क करायची, म्हणजे सगळंच मार्क करायचं असं नाही. पुढच्या रिडिंगला मार्क केलंच फक्त वाचलं पाहिजे. आणि मार्क करताना कोणता MCQ आलेला आहे, बरोबर आहे. हे मार्किंग खूप महत्त्वाचं आहे. आपली पुस्तकं कुणालाही द्यायची नाहीत. आपली पुस्तकं आपल्या सोन्यासारख्या आहेत, गोल्डसारख्या आहेत, ती जपून ठेवायची, लक्षात ठेवा, खूप महत्त्वाची ती. फार्मॅकॉलॉजीचं पुस्तक, पॅथॉलॉजी, आणि एक लक्षात ठेवा कोणत्या विषयाला कोणती पुस्तक वाचायची हे आत्ताच फाईंड करून ठेवा. मला पॅथॉलॉजीचं फादर रॉबिन्सच वाचायचं नाही, मला पॅथॉलॉजीचं कुमार रॉबिन्स वाचायचे, हे फिक्स करा आत्ताच. ते घाबरून जायचं नाही फादर रॉबिन्सची जाडी बघून. कळालं का? मी काही करू शकतो, मी हे जिथं हात घालेल तिथं मी पाणी काढतो, असा विश्वास पाहिजे. मला जेव्हा MD-PSL भेटलं होतं तेव्हा मुंबईमध्ये मी माझ्या मित्रांना पार्टी दिली होती. ते सब्जेक्ट काय का असो, मला घेणं देणं नाही, मी त्या सोनच करणार, हा विश्वास होता मला. कळालं का? मी काय म्हटलं, काल जसे मित्र बोलले तुम्ही काय बोलू नका, थांबा, माझं विसरतोय बोलायचं. कळालं का? विठ्ठल सर काय म्हणलंय, तुम्ही स्टिकअप राहू नका, ते काय सर्जरीज लय भारी असते, काय नसते, सायकॅट्रिस्ट लय भारी असते, काही नाही. तुम्ही सगळेजण ओरिएंटेड आहात पैशाच्या दृष्टीनं. तुम्ही असे बना की तुम्ही गरिबाच्या झोपडीमध्ये पण खणकले पाहिजेत आणि त्या पंतप्रधान नरेंद्र मोदी समोर पण खणकले पाहिजे. ओरिजिनल नाणं बना. कुठेही पडलं तरी ते येणार. हिरा असेल तर तो कोळशाच्या खाणीमध्ये पण हिरा आहे आणि तुमच्या लंडनमध्ये ठेवला तरी तो हिराच आहे. खरा हिरा बना. एकदा तुम्ही खरे बनलात ना, म्हणजे काय बनायचं, तर डेडिकेशन करा जे तुम्हाला काम त्या नियतीनं दिलेलं आहे. कळलं का? कोणतंही काम करायला लाजू नका. कळलं का? कोणतंही काम असू दे, बूट पॉलिश करायचं काम असू दे, पेपर वाटायचं काम असू दे, हॉटेलमध्ये पुसायचं काम असू दे, हे काम करा असं तुम्हाला म्हणत नाही मी, उदाहरण द्यायला फक्त. कळालं का? कोणतंही काम असू दे, काम करायला लाजू नका, मेहनत करायला मी कमी पडणार नाही, मी माझे 100% देईन, मला यश काय भेटायचं ते भेटू दे. म्हणजे डू गिव्ह युअर 100% अँड बी प्रिपेअर फॉर द वर्स्ट. मला वाईटातलं वाईट मला भेटू शकतो याची जाणीव ठेवा. कळलं की नाही? मी प्रत्येकाला सांगतो मी आज मरणार आहे ह्या भावनेने मी काम करतो. सगळ्या पोरांना सांगत असतो मी, बरोबर आहे की नाही? मी आज मरणार आहे नाही हे सांगता येत नाही ना, म्हणू शकतो की नाही आज मी? मग आजचे कामं मी आज पटकन संपून टाकायची, कशाला त्याची वाट बघायची? बरोबर नाही? विवेकानंद म्हणायचे की मी आज मरणार आहे ह्या भावनेने मी जगतो आणि आलेलं काम मी शिस्तीमध्ये प्रामाणिकपणे संपवून टाकतो. तसंच तुम्ही तुमच्या अभ्यासामध्ये पण करा. जे कराल ते थोडंच करा, क्वालिटी करा आणि प्रामाणिकपणे करा. अजून एक वाक्य मला आठवत आहे, इफ युअर ब्रेन नोज देन ओनली युअर आईज कॅन सी. जर तुमच्या मेंदूला माहीत असेल तरच तुमचं डोळ्यांना दिसते. आता सर्जरी करत आहे, कट 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 काढते ते फाडून काय काय, तुम्ही बाजूला उभा असतात इंटर्न, तुम्हाला काहीच कळत नाही काय चाललंय, कारण तुमच्या ब्रेनला माहीत नाही ते. कळलं की ते माहिती करून घेण्यासाठीच आपल्याला मेहनत लागते आणि कठीण परिश्रमाला पर्याय नाही. अजून एक कन्सेप्ट सांगतो, मला पीजी सीट पाहिजे, मला एकच सीट पाहिजे फक्त, आणि सीट अवेलेबल किती आहेत? 1000 आहेत. काहीच कॉम्पिटिशन नाही. आपण उलटा विचार करतो, अरे इतक्या लोकांनी अर्ज भरलाय, 10 लाख लोकांनी अर्ज भरलाय, 1000 सीट आहेत, मला कसं भेटणार? चुकीचा विचार करता तुम्ही. विचार काय करा, मी एकच आहे, मला 1000 सीट अवेलेबल आहेत, कॉम्पिटिशन काहीच नाही तिथं, मी येणार आहे पहिला, असा आहे आत्मविश्वास ठेवा. कळलं का? आणि मेहनत करायला कधीही लाजू नका. खूप मोठे व्हाल तुम्ही, खूप मोठे व्हाल. मी मोठा होणार आहे ह्या भावनेनंच तुम्ही प्रत्येक काम करा. ठीक आहे? आणि तुमचं 100% द्या तुम्ही. कुणाला अनॅटॉमी भेटल, कुणी MBBS वर मेडिकल ऑफिसर होईल, चांगला मेडिकल ऑफिसर पण आहेत बरं का. म्हणजे आज कसं झालंय, आजची अवस्था अशी झाली मेडिकल एज्युकेशनची की MBBS जसं DEDची अवस्था झाली होती आता पण आहे, तसं अवस्था होत चालली आहे. गल्लोगल्लीमध्ये आता मेडिकल कॉलेजेस येत आहेत. त्याच्यामुळं आपल्यापेक्षा जास्त BMS लोक नॉलेज गेन करण्यासाठी, स्किल ॲक्वायर करण्यासाठी प्रयत्न. मी इंटर्नशिप करत असताना मला MD करायचंच नव्हतं, कारण MD करू शकत नाही हा विश्वास माझ्यामध्ये होता. कारण मला मेडिकल ऑफिसर व्हायचं आहे आणि त्याच्यामध्ये जे जे लागतं ते मला पटपट शिकून घ्यायचं आहे. मला ब्रॅन्ड लावता आला पाहिजे, मला एपिसोड करता आली पाहिजे, मला डिलिव्हरी होताना ती बाई नॉर्मल होणार आहे का नाही हे कळलं पाहिजे डिलिव्हरी होण्यापूर्वी. म्हणजे मला PSC वगैरे रेफर करता येईल, ती किती वेळा डिलिव्हरी होणार आहे हे मला कळलं पाहिजे, तिला सीझन लागतं का लागत नाही हे मला कळलं पाहिजे. बरोबर की नाही? मला तुमची राईल्स ट्यूब टाकता आली पाहिजे, राईल्स ट्यूब ट्रॅक्यात गेली नाही पाहिजे, स्टमकमध्येच गेली पाहिजे. बरोबर की नाही? फॉरेन बॉडी नोजमधली काढता आली पाहिजे, इयरमधली फॉरेन बॉडी काढता आली पाहिजे, वॅक्स काढ. ह्या ज्या छोट्या छोट्या इमर्जन्सी आम्ही PJ मेहता पुस्तकातून वाचायचो. अरे याला हे करायचं, अरे याला हे ड्रग द्यायचं, अरे हे इमर्जन्सी आहे. हे सगळं आम्ही यासाठी म्हणून मी तर GPचे पुस्तक घेतले होते, GP कशी करायची. हे बाय लक किंवा बाय एक मला ते PG भेटला आणि हा मार्क भेटला. तर मला असं म्हणायचंय, सगळ्यात महत्त्वाचं आहे पोटाची भाकरी. प्रत्येकाला PG भेटणार नाही. त्यामुळे प्रामाणिकपणे पूर्णपणे आपलं लिमिटेशन आपण ओळखा, आपले पॉझिटिव्ह पॉईंट आपण ओळखा आणि त्यामध्ये वृद्धिंगत करा. जे लिमिटेशन्स आहेत ते कमी करण्याचा प्रयत्न करा, त्याच्यावर मात करा. उगा आणि खचून जाऊ नका, अरे मी काय करू रे, माझं असं झालंय, मी काय करू असं झालंय. कारण आजच एक पत्र आलं युनिव्हर्सिटीचं, 2019 बॅचला जे विद्यार्थी आहेत त्यांना 5th अटेम्प्ट अलाउड केलेलं आहे NMCनं. आजच पत्र आलेलं आहे. जर कोणी विद्यार्थी असेल ज्याचा 4th अटेम्प्ट पण झाला आहे आणि तो फेल झाला आहे तर त्याला 5th अटेम्प्ट पण देता येतो. थँक्यू.
Hello, students. You are so lucky to have such dedicated teachers in our medical college. They are ready to give you knowledge by giving these lectures, demonstrations, practicals and clinics. But from your side, you should attend them and acquire all those skills. See, and this is the period when you can make mistakes and you can learn from them. But in your future life, if you make mistakes, you see the violence which is going on in government as well as in private hospitals where the patients beat the doctors. So, gaining more and more knowledge, acquiring these skills at this period, and by attending all these, this is must for you. So, Before this, before last 3 batches, last 3 years, they were COVID era. Those students were not coming to the clinics. But now the pandemic is over. So I sincerely request all the students, you are the second year and third year students, I don't know whether first year students have come, but you should and must attend. And if you have any problems, you can go to any teacher at any time of the day and they will teach you. We have that much confidence. And as madam has told you, you should know how to behave with the patient. Even the bad situation should be explained in a very proper way. And if you have not acquired that skill of explaining to the patient, then you know what are the consequences of that. So all the best to all of you. I think this is a very useful lecture for all the students, and you shall gain much knowledge from this.
Hello. अजून एक की when you are going in second year, you are applying for that course, कुठला mero course. आणि many of the students are seeing videos of lectures, and that is the one big reason the students are bunking the classes, not attending. But you attend that video, you see that videos during night time or after 5 p.m. when you are free. Don't bunk the classes and only see videos and come inward. That is not correct. पण नाही आणि असं तुम्ही you don't learn medicine also. Any clinical branch, when you only touch to the patients, do clinical more science. So many infrastructure, so many teachers, experienced teachers are ready to teach you. तर माझं असं म्हणणं नाही की तुम्ही ते व्हिडिओ वगैरे बघू नका. You see, but in your रिकाम्या वेळेत बघा, ते फावल्या टाईममध्ये बघा, की संध्याकाळच्या नंतर वगैरे, की बाबा एखादं लेक्चर तुमचं मिस झालं किंवा काय झालं. आणि यू अटेंड इन लार्ज नंबर्स. वेन समोरासमोर जेव्हा आपण शिकवतो किंवा आपलं इंटरॅक्शन होतं, तर ते त्यावर आपण जास्त कॉन्सन्ट्रेशन देऊन ऐकतो. एखाद्या वेळेस तो टॉपिक आपला वाचून पण झाला नाही, तर ॲटलिस्ट यू मेमोराइज दॅट, की बाबा दॅट सर और दॅट मॅडम हॅज taught me these points. So you can write answer for theory also. So attend in large numbers, all lectures, clinics, and you join that class. But during evening or night time you see that videos. Okay, thank you.
I thank Deputy UG Dean, Dr. Dantakale ma'am, the panelists for today, Dr. Dharke ma'am and Dr. Dange sir. I thank all the faculties present, and I hereby declare that morning session has been concluded. We shall be meeting at 4 p.m. same venue. Kindly please be present. Thank you.
Good afternoon to all the honorable guests, respected faculties and the enthusiastic minds present over here. I am Ashirwad Patak, a first year MBBS student at Dr. V.M.G.M.C. Solapur. It gives me immense pleasure to extend you to a very warm welcome on the behalf of Dr. V.M.C. Memorial Government Medical College Solapur, who has clubbed all of us for the first of its kind mega health fest, that is the Aarogya Nagari. The unique concept has been devised by the medicos of our institute for the benefit of the common man on the occasion of 60 years of its establishment, titled as Hirak Mahotsav. We are familiar with the great quotation, change is the only thing which is constant. It is the law of nature which cannot be bypassed. Some changes leads to advancement, whereas some changes lead to abasements. As a part of this ever-growing medical field, it is really important for us to be a part of this advancing changes of our field and witness this mass revolution. So on the account of our today's chairperson, Dr. Vinayak Doizat sir, Assistant Professor in the Department of Physiology, I would like to welcome Dr. Kiran Sada ma'am, a renowned obstetrician and gynecologist and a President-elect of Indian Medical Association Solapur, to guide us upon the topic advances in the basic obstetrics through her insightful words. Handing over my mic to ma'am.
At the outset, I thank organizers. I have designed this lecture like this, very simple things, how obstetrics has evolved. evolution of obstetrics. First, in our days, there was no pre-marriage or preconception counseling. There was nothing concept like that. But nowadays, people are coming, girls and boys are coming to take the consultation about, can I marry with a B positive blood group girl, or there are some misconceptions. But what we have to keep in mind is, we have to see, next slide please. We have to see that HPLC, high profile liquid chromatography, or you can say hemoglobin electrophoresis, which is one of the most important thing to be done, because with this we will know the thalassemia, sickle cell anemia traits, and we don't want a single baby of thalassemia on this earth. Then we have very particular about that. Two threats should not be married. Thalassemia trait means carrier of thalassemia should not marry with a carrier of thalassemia. So if you are having, there are no signs and symptoms of trait to see that I am having this problem or suffering from this thing, and I will come to know that I am a sickle cell trait or thalassemia trait. I know very highly educated people, some doctors, they are carriers of these diseases. So we should get our test done before marriage. HIV, HBsAg is okay. Now this trend is coming. So your generation will see that people are coming to you and asking about the tests. Preconception counseling. Preconception counseling means, we know that nowadays age of the marriage is increased, and because of these late marriages, pregnancy is late, and then late pregnancy problems, advanced age problems, we are facing it. So before marriage, if you are planning for a pregnancy, people who comes to you, you can advise them to do the tests like this same thing, CBC, urine, to know the basic hemoglobin, because after once conception has occurred, to treat anemia is little bit difficult. So better first correction of anemia and then try for the pregnancy. Start for the folic acid before you are having conception, and if not done, hemoglobin electrophoresis, HPLC or HIV HBC, that should be done before conception. Day before yesterday I had a patient. She came to me HIV positive आहे आणि मला 4था महिना आहे. So I said, since when you are HIV positive? She said, since 2 years of age. Means her mother was HIV positive and she had got that infection transplacental. At present she was having, she was 24 years, and she was managing very nicely that with HIV. So it is not like that. But if you are having the disease, then you have to tell your patients what is the treatment and how you can manage the pregnancy. So for this purpose, management of pregnancy, we should know the things about this diseases, whether our patient is having or not. Next, ANC during pregnancy. Now the very interesting part comes. This is the topic very close to all obstetricians' heart, and I think each and every girl also see a dream of becoming a gynecologist in our days. But nowadays, you people are wise. You don't want to disturb your sleeps. You don't want emergencies. So you are not giving preferences to OBGYN. No? But what will happen once our patient? Now what we are going to do? I will tell you what we used to do, what you are going to do. So you will come to know the advances, right? When a patient used to come to us with missing period, then the first thing we used to do was per vaginal examination. Our two fingers were our probe, because even in 1992-94, it was not easily available that sonography was having with each and everyone. Very few people were having sonography machines. Even in Solapur, in 1994, only one person was having vaginal probe. So till 1990s decade, sonography was occasionally done things. When we were residents, we used to do, whether it is breech or vertex, to see that, very simple, whether heart is there or not. We used to do very simple things with that sonography, because no advances like today were there. So we used to do per speculum, per vaginal examination. We used to feel the size of uterus with our hands, 6 week size, 8 week size. I think nowadays no resident will be able to tell the 6 to 8 week size, means 7 week size. Really, we have lost that art of doing per vaginal examination. Till today, we can do very nice examination. We feel the softness or firmness of the tissue with our fingers, and we could predict that this is pregnant cervix and this is not pregnant cervix. So the softness of cervix, if it is like lips, then we used to take in our mind that she is pregnant. But if the cervix was hard in a patient, not about pregnancy, but hard like this forehead, then suspicion of cervical malignancy was coming to our mind. So this feeling of tissue with two fingers is not seen nowadays. We used to feel the pulsations and colors of that vagina. Color of vagina is bluish, feeling pulsations. You may have learnt in anatomy, Jacobian sign and Chadwick sign and blah blah that. But we have seen it, though we were studying the names of signs, we were doing practicals with that. So pregnancy was diagnosed with such things, and sometimes we used to do the urine pregnancy test, not for each and every patient. Nowadays what is happening, when you will start practicing, patient is coming with card. Even today with us also, patient is coming with urine test done at home and telling that urine test is positive. And now further we have to do the things. Bleeding in the first trimester of pregnancy. If a patient had a syncopal attack, syncopal attack, चक्कर येऊन पडली कोणीतरी पेशंट ओपीडी, तर आम्हाला सस्पिशन यायचं, तिचे LMP विचार, if period is missing and she is having syncopal attack, the first thing which comes to our mind is ectopic pregnancy. So such things we used to use for diagnosing. If some blackish, old, bleeding colored per vaginal bleeding is seen on per speculum examination, or our fingers, gloves stained with black color bleeding, we would have suspicion of miscarriage, like missed abortion. You all may be knowing missed abortion and blighted ovum. There is a difference between missed abortion and blighted ovum, which is now differentiated on sonography. But in those days, missed abortion, blighted ovum, threatened abortion, everything was abortion for us. Now, USG, the great thing, which is a very you can say USG or sonography is has become eyes of obstetrician. Without USG, doing practice nowadays is just impossible. So, once patient comes to you, what you are going to do means, I am also nowadays, what I am going to do nowadays, I will ask to do the sonography first. I want to see whether the fetus is single or multiple, whether it is live or dead, whether it is having sufficient amount of hormones, means choriodecital reaction, whether it is good or poor. So progesterone hormones, progesterone or SCG hormone is required to supplement or maintain the pregnancy. We will come to know with these things. And in this way we can avoid abortions. Very interesting thing I want to say, how many of you know that first trimester sonography can predict the pregnancy induced hypertension or IUGR, PIH or IUGR? How many of you know? It is very interesting because this evolution has very in the recent days. So if we do the Doppler study of uterine artery left and right, and if there are some changes, we can predict that this patient will have PIH and this patient will have IUGR in her late pregnancy. So we can start the things like aspirin, low dose aspirin or heparin to prevent such things, or we can be very vigilant to prevent the problems, complicated pregnancies. Do you know that if because of IVFs nowadays multiple pregnancy is very common. So do you know that if one patient to you is having triplet or quadruplet, and it is very difficult, no? 4 babies in womb cannot be taken till date nowadays. So we can reduce the number of embryos. Do you know this? That is called as fetal reduction. This is very nice technique for those who are having multiple pregnancies and don't want even twins also. They can reduce the number to 1 at the age of 8 to 10 weeks. Second, third month, we can reduce the fetus, of course with some risk, but we can reduce the fetus and have a nice normal for one singleton pregnancy. Very nicely in first trimester only we can predict the Down syndrome. Down syndrome anti-scan, knuckle translucency scan is done at 11 to 14 weeks, and in that we measure the transparent space on the nape of neck of the baby, and we do the double marker test corresponding with that, and these two combined give a result that this baby will be suffering from Downs or not. So such a great thing, no? We now it is said that no, not a single Down baby should take birth on this earth. So we all are supposed to do all these things, and we should know about these things. If there is some doubt in Down's blood test, that dual marker test, the further NIPT or non-invasive prenatal tests. With only blood test we can predict whether the baby is having Down syndrome. Do you know Down syndrome? Mentally retarded babies, no? So we should not allow any baby to have Downs. Then this thing I know that you all are knowing, medical abortions. Previously there was no term like medical abortion. Medical abortion means abortion with tablets. So if a lady doesn't want pregnancy and she is pregnant, so if she comes earlier to you within 1.5 months, you can give some pills to her orally and vaginally, and she can get rid of that pregnancy. So it is very simple thing. Nowadays it has become very simple and very what you can say, without any risk you can do this. But definitely before doing medical abortion one should do the sonography, must, because if the baby is bigger, larger, because of wrong types, or if it is in tubal pregnancy or ectopic pregnancy, then disaster may happen. So better do sonography, see that it is less than desired size, and then medical abortion with tablets can be done. Now let us proceed to second trimester. We used to do per abdominal examination. Per abdominal examination, we used to put hand and we used to put the grips, Paulink's grips, and all these things which are given in book at the level of umbilicus 24 weeks, at the level of pubic symphysis 12 weeks, that you know all. CP sternum 36 weeks. But nowadays people are not ready to do per abdominal examination. They will put probe and see, measure the biparietal diameter of the baby, means head diameter of the baby, or femur length of the baby, or abdominal circumference of the baby, and we will estimate the gestational age. Before my era, means before in 60s and 70s, our teachers have used one fetoscope, Pinard fetoscope. It was a funnel-like instrument, and they used to listen the heart sound to keeping that funnel to the abdomen of the patient, like that. Now we had listened heart sound with stethoscope, and now you people are going to listen heart sound with Doppler. Very handy machine nowadays coming, just palm size, and you can carry anywhere in ward, and just take the probe, very small probe, put on the abdomen, and you listen the FHS, and ask the patient to listen also. She will be very happy to listen. माझ्या बाळाचे ठोके आहेत का हे हृदयाचे. She is also very happy. So the advances are very helpful to even patients and doctors both. Second trimester abortions were also very common in those days, repeated abortions. So because of cervical dilatation, incompetent cervix, patients used to get abortions. We used to do cervical encerclage with nylon, but suture material nowadays, these are very, very potent. These are antibiotic coated, so their effectiveness is increased quite a lot. So this problem of encerclage is solved very in a nice manner. You know, hydrops fetalis means if RH incompatibility occurs with a baby in a severe form, then there is edema on the fetus all over the body, and the life is threatened or endangered. But we come to know this hydrops fetalis on sonography, and you know, up to my surprise, I was also not seeing in my UG PG student lifestyle who is giving intrauterine blood transfusion. Because in hydrops, what happens in RH incompatibility? What happens? Loss of RBCs, breakdown of RBCs, so baby becomes anemic, and this goes in fetal edema all over body. So if the baby is provided with the compatible blood group, then it is saved. And I have seen with expert hands n number of babies saved in Solapur. So when I saw first time intrauterine transfusion, really it was very thrilling. Baby in uterus, we are puncturing needle without anesthesia. We are puncturing needle we are catching the cord and we are inserting needle in the cord vein, which is taking blood to fetus, and we are giving blood. How the blood is matched? O negative blood is given, so which is matched to that all. So this is very interesting part which I have seen after becoming my post-graduation, after doing my post-graduation. So intrauterine transfusion, now it is very common thing, experts are doing it very commonly. Just couple of days back, I saw one post and listened to the news of doing intrauterine surgery of spina bifida. Indian one gynecologist. Yes. So I was, if possible, we would have invited him as an alumni here, and very proud to announce that he is alumni of this college only, and he has done. Dr. Singh, he has done correction of spina bifida in intrauterine. So the quality of life of that baby is definitely improved a lot. So science is advancing quite nicely, and everyone should take benefit of that. Laparoscopy, sonography, infertility. Previously what used to happen, only OBGYN was the specialty. But now fetal medicine, they don't practice delivery and infertility. Infertility, IVF center, they don't do the sonography of anomaly scan. So everyone is focusing on a narrow portion and becoming more and more expertise in that. So just like ophthalmologist, what we know, the retina specialist, cornea specialist, previously ophthalmologist, but nowadays everyone, every branch is having so many sub branches and super specialities, we can say like that. So now let us come in third trimester. We had faced very much stress, sleepless nights for breech, twins, PIH, heart disease cases. Unexplained sudden IUDs and placenta previa abruptio were monsters for us. We were always having stress and tension. Don't know what will happen to this. PIH patient है तो पता नहीं कब इसको abruptio हो जाएगा, कब इसका IUD हो जाएगा. So if patient of this placenta previa bleeds profusely, we used to rush to take the blood bags and blood bottles, because their relatives, they would have said, we don't know where to go. And in those days, I don't see this nowadays, that residents are running for taking bloods and all that, but we run so many times for collecting blood bags and collecting even plasma volume expanders like H-stars. So this was our these were our days. Now what we are doing today, we all diagnose all these complications of pregnancy very nicely with help of this 2D, 3D, 4D sonographies. Even 5D sonography is also there. We can see all dimensions of the fetus and literally how the fetus will look, that can be seen with help of sonography. And very regularly we do uterine artery Doppler, color Doppler, umbilical artery color Doppler, and middle cerebral artery color Dopplers. These three are very commonly done, and we will predict with help of these Doppler studies so many problems which we would have faced in prior days. Now during the delivery. Labor room in our days and labor room at present days has changed a lot. Whenever a patient comes to us in a labor, we used to do again our 2 fingers for per vaginal examination, per abdominal examination, palar, jaundice. We used to see such thing, and before going to blood investigations, we will be knowing that patient is having icterus or not. Patient is deadly pale or mild palar is there. Heart sound on right side or left side, head up or down, oblique grips, how much head is fixed, 3/5 palpable, 4/5 palpable. These were the standards for us while I was a student. But we used to do PV examination, cervical dilatation, how many centimeter, effacement, how many percent, then whether the membranes are present or not, where is the station of head, and whether the pelvis is adequate or not. This we used to do. And partograms. You must have seen your Johnson textbook, partograms of the progress of the labor, to see the progress of the labor. But nowadays, these things have gone. We are having continuous electronic monitoring, fetal Doppler or non-stress test, NST, CTG, cardio topography, right? So these machine is belts are around the abdomen of the patient. Patient is given one switch in her hand. If baby moves, she is allowed to press the button, and we see minute to minute, second to second variations in the heart rate, heartbeat of the baby. And while the contraction is coming, how the heart rate decelerates and how it comes up again. So this NST and CTG is very, very helpful to monitor the patient sitting at our home. They can send the video of 5-10 minutes of CTG and NST, and you can take the decision. One thing is true, because of extra monitoring, extra care, incidence of LSCS has increased a lot. We have to agree. This is one of the reason, not the sole reason, but one of the reason. So, continuous fetal monitoring is really very helpful. And delivery, there are n number of modes now. We engage patient somewhere else to see some videos or some music, and diversion of their mind is done to tolerate the pain. And this is one thing. Another thing, you may have listened painless labor with epidural anesthesia, which is given for hours together, 6 hours, 8 hours can be given epidural anesthesia, and patient is not having pain of the labor pains. So these are the things which have came new in this thing. Drugs like prostaglandin, cerebrine or pramigine, and what you say, misoprostol tablets, these are having a very important role in enhancement of the labor. So definitely in our days, that laminaria 10 and buscopan suppositories, and these were things, and nowadays the drugs are very potent and very safe drugs with such like that. PPH, the nightmare of each and everybody, every obstetrician. When and where patient will land up in PPH, nobody can predict. But previously, we were really having threat of PPH. We never left patient alone after delivery for at least an hour. But nowadays, there are some drugs, there are some methods, and I am very proudly can say that in last 850 deliveries, I had not a single PPH. Because we are having very potent drugs and little bit vigilance we can prevent the PPH. And if at all PPH occurs, we are having many surgical procedures or some medical procedures, like you may not have listened about the instruments, that Panikar's cannula or Bakri balloon. These are the things very commonly used even in periphery and small places also. These things have a very important role in preventing PPH. And many students are focusing and learning newer techniques in surgery, like internal iliac artery ligation or some procedures which are very helpful to prevent the excess blood loss. So PPH is not nowadays that much nightmare which was previously. After delivery, now we see about the postnatal care. Previously, once delivered patient, she used to disappear from our list. But now, people are careful and they are taking care of their health. They will come to you. They will ask you about the contraception. They will ask you about the breastfeeding and all these things. We have to consult them with a pediatrician about immunization. All these things we are doing it very regularly and nicely. So the practice in our days and the practice what you are going to do, definitely very quite I will say, काही दिवसांनी असं वाटेल की काही साम्यच नाही राहिलं त्यात. आम्ही जे शिकलो, when I was student, no, I have seen only one laparoscopic surgery in 1990. Only one laparoscopy surgery in whole 3 years time. And now when I came to Solapur after marriage, every single day there are n number of people who are doing laparoscopic surgeries. And even varicocele, this is also done treated with laparoscopy. So advances are coming and we have to accustom with that, and we definitely this technology we have to accept it, and we should become a techno-savvy person. Just like our smartphone, we have changed our old Nokia phones and we have accepted the newer technology. We also accept newer techniques and advances in our OBGYN. Thank you. Thank you for listening.
Thank you so much, ma'am, for your really impactful words. Ma'am gave us an extremely simplistic approach, explained her own experiences, and explained us about all the 3 trimesters in a very deep manner. I feel that obstetrics and gynecology, we had some notions that it is a really hectic branch. We can't take it and we are not capable to do it, but actually it is such a unique branch, because I personally feel that there are these obstetricians are giving birth to 2 lives, the life of a children and a life of a woman as a doctor, life of a woman as a mother. So that's why I feel really that this is a unique branch and everyone must take it up. So thank you so much, ma'am. As we all know that our life is full of hurdles and challenges. Some people enjoy them, whereas some people fail to overcome it. So the result is ultimately dependent upon the approach towards the situation. So looking forward at our medical profession, there are a series of ups and downs, heartbreaks, and also the sleepless nights. However, this is the one which makes a human convert into a doctor, or makes the human potent to become a doctor. So, believing in this idea, on the account of our today's chairpersons, that is Dr. Pradeep Kasbe sir, the Associate Professor in the Department of Surgery, and Dr. Vinayak sir, the Assistant Professor in the Department of Physiology, I would like to welcome Dr. Ramakrishna Londe sir, the President Emeritus of the Indian Medical Association. Giving some brief introduction about sir. Sir has pursued his MBBS from GMC Sambhajinagar, and he is also an alumnus of our prestigious institute. He has pursued his diploma from our institute, and we are really grateful to have him. And I would like sir to share his few insightful words on the topic, the approach toward our practical approach towards the challenges in our profession. So handing on my mic to sir. Thank you, sir.
पुढं बसा, पुढं. तुम्ही आता बरेच दिवस हे इंग्रजीमध्ये भाषण ऐकत असाल आणि हे टीचर मंडळी असे आहेत ते आता एकदा माईक जर समोर आला तर सोडत नाही सांगायचं म्हणजे नॉट लाईक दॅट. आणि मॅडमनं माझं काम फार सोपं केलेलं आहे. तिने परिश्रम करून डिलिव्हरी केली बाळाची आणि माझ्याकडे आलं तर मी पेडियाट्रिशियन आहे. सोपं आहे, बाळाला हँडल करायला सोपं नाही. आणि नॉर्मल डिलिव्हरी झाली असं मी गृहीत धरतो. प्रथमतः ही जे आरोग्य नगरी आरोग्य निमित्त ठेवले आहे त्यानिमित्तानं आम्ही पूर्ण टीमचं हार्दिक अभिनंदन करू इच्छितो. माझ्यामध्ये जवळजवळ 4-1 महिने तरी लागले असतील या गोष्टीला करायला आणि परिश्रम घेऊन तुम्ही तयार केला आहे. त्यानिमित्त आम्ही परिसर फिरून पाहायला माझ्या काळामध्ये एवढा पाहायला नव्हता. मी सांगायचं विजेला एवढं आम्ही इकडे येत नव्हतो सांगायचं. आणि ते तुमच्या सर्वांचं मी अभिनंदन करू इच्छितो. IIM महाराष्ट्र स्टेट कडून मला काल मी याला होतो धुळ्यात आला जळगावला होतो तो हाच विषय होता. डॉक्टर अशोक पण तिथं आले होते आपले नास्कर प्रश्न केले आणि तोच होता एक चॅलेंजेस काय आहेत आपल्यासमोर त्याविषयी मी तुम्हाला थोडंसं यूज करणार आहे. लेक्चर देणार नाही, भाषण देणार नाही, थोडं हिंदी इंग्रजी मराठीमध्ये थोडं एक कन्व्हर्सेशन एक डायलॉग साधायचा प्रयत्न करेल. व्हेरी डायनॅमिक लेडी पास व्हाईस प्रेसिडेंट डॉक्टर ज्योती मॅडम, आदरणीय मॅडम आणि आमचे फिजिओलॉजीचे आणि सगळं नाव घेत नाही आमचे आदरणीय सर कोऑर्डिनेटर अगेन दिस नूपुर छोटे आय डोंट नो बट CHOT छोटे बट यू आर नॉट दॅट मच छोटे, यू आर ऑल्सो ग्रेट पर्सन. ओके. आणि मी कल्याणला पण जाऊन आलेलो आहे सांगायचं म्हणजे मग अशी बोलता विचारलं मी पूर्ण महाराष्ट्र फिरलो, मॅडमला घेऊन फिरलो बऱ्याच ठिकाणी सांगायचं म्हणजे. संतोष कुलकर्णी आमचे मित्र येतील आता त्यांच्याबरोबर पण फिरलेलो आहोत. आणि असं काही नाही, तुम्ही नॉलेज घ्या कुठलेही घ्या परंतु अप्रोच जो आहे तो पेशंटच्या भल्यासाठी करा. मॅडमनं खूप सारखं तुम्हाला टेक्नोसेव्ही सांगितलं. आय ॲग्री टेक्नोसेव्ही राहिली पाहिजे परंतु यू शुड बी ग्रेट क्लिनिशियन. मला पेशंट बैठले की तुमच्या सवयींना व्हायला पाहिजे जागा. तुम्ही टेक्नोसेव्ही असं करू नका, हे करा डायग्नोसिस ते डायग्नोसिस ते करण्यापेक्षा तुम्ही एक चांगल्या प्रकारे चांगलं क्लिनिशियन व्हावं अशी माझी इच्छा आहे. त्यानिमित्ताने मी तुम्हाला सर्वांचं अभिनंदन करतो आणि तुम्ही चांगल्या प्रकारे डॉक्टर व्हावे, चांगल्या प्रकारे क्लिनिशियन व्हावं. आय ॲग्री तुम्ही अकॅडमिशियन व्हायला पाहिजे. एक उदाहरण देतो मॅडमजी तुमची परमिशन घेऊन. एक DNB मेडिसिनचा किंवा DNB दुसऱ्या कुठल्या विषयाचा एक विद्यार्थी असतो, त्याच्यासमोर एक 4 पायाचं जनावर ठेवलं जातं आणि त्याला विचारलं तर डायग्नोसिस विचारतं व्हॉट इज दॅट ॲनिमल. त्यांना सांगतो की इट कुड बी हायपोट्रॉफिड goat or hypotrofid second animal having 4 legs, 2 this horns and ears. परंतु सांगत नाही तो की गाय तो जनावर कुठला आहे डिस्क्रिप्शन करतं. जसं आता रेडिओलॉजिस्ट आम्हाला ते सांगतात, आम्ही पेशंट पाठवतो रेडिओलॉजिस्ट सांगतो की अमुक सांगतो पण टेंटेटिव्ह डायग्नोसिस सांगत नाही. नंतर ते MD मेडिसिनवाल्याकडे तो जातं, त्याला सांगतात ते सांगतो हे ॲनिमल किंगडममधनं आहे, त्याची स्पेसिस सांगतात वगैरे वगैरे परंतु टेंटेटिव्ह डायग्नोसिस ते मी सांगत नाही. ॲनिमल म्हणतं आहे पण मिल्क देते एवढं म्हणतं, दूध देणारा ॲनिमल आहे. पण जेव्हा आमच्या MBBS वाल्याकडे जातो तो सांगायला ते म्हणतात ही गाय आहे. त्याला मला सांगायचं तात्पर्य की डायग्नोसिस जो आहे तुमची एक क्लीन कट डायग्नोसिस राहावी ह्या मतं संख्या आहे. एनिवे टॉपिक गिवन टू मी इज व्हॉट आर द चॅलेंजेस टू दिस यंग डॉक्टर्स अँड मेडिकल स्टुडंट्स. The challenges starts from your admission itself. Then challenges are about this hostel, diet, mess, other things. But we have to accommodate it. I have to adopt it. There is no any second option for it. Then again, there is a treatment given by seniors students. Now at present this ragging is no more there, I think so. It is reduced to little. Again, there is government restrictions about the passing out. If you get admission, you have to pass whole in third year, fourth year within a span of 9 years. Now NMC has declared if you don't pass within span of 9 years, you will be no permitted for this examination. Listen. Again, there are so many examinations starting from NEET, EXIT, PG NEET. Next is again examination. But nowadays, NMC declaring that MBBS last year, this is major, is treated as a exit test. New norms. Again, there are also examination for NRI quota. Those students coming from outside, particularly Ukraine, Russia, all that, Australia, they have to pass this again examination of this common entrance test or qualifying examination. Then again there is the issue of the bond. All state governments are restricted, giving restriction over the bonds also. Again, there are, I can say about these challenges to the medical practitioners particularly. तुम्ही जेव्हा प्रॅक्टिसला सपोज तुम्ही पास झाला आता समजा ग्रेड धरू आपण त्याच्यानंतर पुन्हा तुम्ही PG करा. तुम्ही सगळ्यांना माझी इच्छा आहे की माझी अशी अपेक्षा आहे सगळ्यांनी PG करावं. त्या संदर्भामध्ये मी तुम्हाला आकडेवारी सांगतो आत्ताच्या कंडिशनची. भारतामध्ये जवळजवळ 700 मेडिकल कॉलेजेस आहेत मॅडम आणि त्या 700 मध्ये 1 लाखापेक्षा पुढे सीट्स आहेत 1 लाख अँड अबव. त्याच्यामध्ये PG सीट्स खूप वाढल्या आहेत. 70,000 पर्यंत सीट झालेल्या आहेत. 101% इन्क्रीज इन PG सीट्स. अगेन दिस इज द म्हणजे बिगेस्ट चॅलेंज यू कॅन से. बिकॉज गव्हर्नमेंट काय म्हणतं की डॉक्टरची संख्या कमी आहे. आता प्रत्येक जिल्ह्यात 1 ते 2 कॉलेजेस येऊ लागलेले आहेत आणि ते एवढ्या मोठ्या प्रमाणात मुलं आणि युनिव्हर्सिटी डॉक्टर म्हणजे स्टुडंट फ्रेंडली होऊ लागले. तुम्हाला जरी नापास करायची इच्छा असेल तर करू शकत नाही. असं झालं आहे सांगायचं म्हणजे 2 विषय असतील तर 2 कलेक्टिव्हली 50% पाहिजे 40% पाहिजे. त्याच्यामुळे आता येणारे मुलं खूप सारे येणार आहेत सांगायचं म्हणजे. आणि हे करत असताना आपल्याला खरं तिथं मात्र स्ट्रगल करावं लागणार आहे. तुम्हाला तुमची क्वालिटी म्हणजे राहावं लागेल, क्वालिटी ट्रीटमेंट द्यावं लागेल. तुमच्याकडे कसं जेव्हा तुम्ही प्रॅक्टिस करायला सुरुवात करता तिथे चॅलेंजेस आहेत. प्रॅक्टिसला तुम्हाला जागा घ्यायची आहे, ती कॉस्टिंगचं आहे, हॉस्पिटलचं म्हणजे उभा करायचं आहे. आता इन्स्ट्रुमेंटेशन वाढलेलं आहे खूप सारा त्याच्यामध्ये तुम्हाला कॉस्ट फॅक्टर येणार आहे. ते सुद्धा करत करत तुम्हाला प्रॅक्टिस करायची आहे. दुसरी गोष्ट तुम्ही जेव्हा प्रॅक्टिस करायला सुरुवात करता तेव्हा फॅमिलीचे पण काही जबाबदाऱ्या असतात. आईवडिलांची जबाबदारी असते, बहिणीची असते, भावाची असते. आपलं जर लग्न झाल्यानंतर आपल्या मिसेसची जबाबदारी असते. परत आपल्याला मुलं झाले तर मुलांचं ॲप्लिकेशन असतं, मुलांचं शिक्षण असतं. प्रत्येक ठिकाणी चांगलं शिक्षण मिळू शकत नाही. असे ह्या काय गोष्टी आहेत त्याचा आपल्याला ओव्हरकम म्हणजे करावं लागणार आहे. आणि सुदैवाने एज्युकेशनच्या बाबतीत जर मुलं लहान मुलांच्या तर प्रत्येक तालुक्याच्या ठिकाणी चांगल्या प्रकारच्या चांगल्या क्वालिटीच्या स्कूल्स आता येऊ लागलेल्या आहेत. हे करत असताना तुम्हाला बिग चॅलेंज जर असेल कुठलं सध्याच्या गोष्टीला लिसन व्हेरी केअरफुली. नाऊ द गव्हर्नमेंट ऑफ इंडिया थ्रू NMC they are introducing this common this syllabus including all yoga, allopathy, homeopathy and this Ayurvedic. Now there will not be clear cut allopathy doctor. Now all will be hybrid one because government is going to change our DNA, allopathy this medical DNA. It is very difficult. Once DNA change, it is very difficult to start as a original one. Again, what IME does, because IME is the only parent body, you can take care of all children. Throughout India, we are struggling with government to reduce this education policy, to change the education policy, but government is very adamant. गव्हर्नमेंटला बदलच करायचा आहे. कशामुळे करायचं आहे त्याचं निष्पन्न काही होत नाही, परंतु गव्हर्नमेंटला करायचं आहे. आता मगाशी बोललो आपण स्पायना बायफिडा इन युट्रा. आता आपला इथला विद्यार्थी करतोय, तो आपल्या ॲलोपॅथीमध्ये क्वालिफाईड झाला होता. त्याला जर हायब्रिड शिक्षण मिळेल तर करू शकणार नाही. असं जर केलं गेलं, मला वाटतं तुम्हाला चांगल्या प्रकारे शिक्षण मिळणं म्हणजे पुढल्या वर्ष 23-24 पासून ते येता गव्हर्नमेंट आणू लागलेलं आहे, पण आम्ही त्याला आणू देणार नाही. सांगायचं म्हणजे आम्ही गव्हर्नमेंटला भांडू, ऑल इंडियाचे लोक भांडू आणि त्याला अशी ऑल वर्ल्डचे लोक पण आणू आणि प्रोटेक्ट दिस पॉलिसी. Then again, there is a big threat about the mixopathy, because you have to fight with your colleagues. Again, I have to fight with these all BMS, V.M.G.M.C people. They are very notorious. They are very sharp. They are smart fellow for doing general practice, all that things. One thing about our diagnostic pattern. Now, Madam told about what is the new technology about this all the diagnostic purposes. Madam also dealing with on diagnostic purpose also. But main thing is about when patient comes to us, the patient knows every about the disease. So called Google University. सगळ्या गोष्टीची माहिती घेऊन येतं. आपलं सुद्धा त्यांना DNA सोडून बाकीच्या माहिती काढलेल्या असतात, सगळ्या गोष्टी काढून देतात. मग ते तुम्हाला फार मोठं चॅलेंज आहे. कन्व्हिन्सिंग पॉवर तुम्हाला वाढवावं लागेल, तुम्हाला कन्व्हिन्स करावं लागेल आणि सगळ्या गोष्टी त्याला सांगून तुम्हाला ते प्रॅक्टिसमध्ये तुम्हाला उतरावं लागेल. एक मोठा थ्रीट असेल त्याच्या काळातला. वन थिंग अबाउट द MMC. Our MMC is very good one. In Maharashtra Medical Council is a very unique one amongst all councils. In India, MMC Maharashtra Medical Council is a unique one. All things are on this online only. There is no need to go for Mumbai for registration, all these things. One profile will be made online also. That is doctor friendly, or you can say the student friendly. संघटनेच्या माध्यमातून डॉक्टरवर जे काही प्रॉब्लेम येतात, विशेषतः असॉल्ट ऑन वर्क प्लेसेस. तुम्ही काम किती करायला पाहिजे त्याच्यामुळे आम्ही गव्हर्नमेंटशी आम्ही निरीक्षण करतो. त्यांना कमीत कमी काम दिलं पाहिजे, टेन्शन न दिलं पाहिजे आणि इजी फ्रेंडली त्यांनी काम करावं वर्क प्लेसेसमध्ये. आणि वर्क प्लेस हा म्हणजे असॉल्ट फ्री राहावं, म्हणजे एखादा असॉल्ट होऊ नये या संदर्भात आपण करतो. आणि आम्ही म्हणजे स्टुडंटबरोबर, पीजी स्टुडंटबरोबर आणि बाकीच्या मेंबर्सबरोबर आम्ही सगळ्या गोष्टी करायचा प्रयत्न करत आहोत. आणि या निमित्ताने मला इथं बोलायला संधी दिली आणि माझे शब्द तुम्ही ऐकलेत, त्या निमित्ताने मी सर्वांचा मी आभारी आहे. परत एकदा या कॉलेजमधून तुम्ही शिकून चांगल्या प्रकारे नॉलेजेबल व्हावं आणि पूर्ण भारतात नाही पूर्ण जगामध्ये तुम्ही स्वतःचे संदीपनं जसं डंकापीठ म्हणजे केलेलं आहे साधा समुद्रापलीकडे, तसं तुमचं पण नॉलेज तसं इतिहास आहे. मला वाटतं याला चायनामध्ये आपले इथले डॉक्टर गेले, पोर्टुगीज गेलेले होते ना, असे काय आहेत परदेशामध्ये सुद्धा लोक आपले चांगले म्हणजे त्या मातीमध्ये गुणधर्म असा आहे, टीचिंगमध्ये जसं आहे, तुम्हाला चांगल्या प्रकारे नॉलेज मिळेल. आणि त्यानिमित्तानं तुमच्या माझ्यातर्फे IIM महाराष्ट्रातर्फे तुम्हाला हार्दिक शुभेच्छा. धन्यवाद.
Thank you so much, sir, for your impactful words and sir's data explanation. And sir, at this age, sir is even working for students. This is a very great thing which we all must appreciate. And today there was a unique combo of a gynecologist and a pediatrician. So we have discussed very sensitive clinical branches over here. So now I would like to call upon our chairperson, Dr. Pradeep Kasbe sir, Associate Professor in Department of Surgery, to felicitate Dr. Londe sir. Big round of applause.
मॅडम तुम्ही नाही आला मॅडम आम्हाला स्टेटला घेऊन जायचं
Now I would call upon Dr. Vinayak Dwezat sir, Assistant Professor in Department of Physiology, to felicitate Dr. Sada ma'am. Thank you, sir. Thank you, ma'am. So concluding our today's conference, I would like to add that meeting of two persons is like a contact of two chemical substances. If there is any kind of reaction, both of them get transformed. We have learned a lot of things today from sir and ma'am, and I hope that sir and ma'am have also enjoyed the session. I sincerely appreciate everyone's attention, and thank you all for being over here.